Good morning, afternoon, or evening, depending where you're at, American Kinesiology Association. Today, I am here with Dr. Brett Scofield with a topic that many of us have been talking about wanting to actually have on for, I don't know, probably about a year or more. So I'm super thrilled that he's willing to join us and have these conversations. Dr. Scofield comes as the Executive Director from the Center of Collegiate Mental Health. He's the co-interim Senior Director of the Center for Counseling and Psychological Services. Additionally, he is, as a psychologist, he is practicing counselors, working with college students and staff for a variety of mental health issues and concerns, specializing in anxiety, OCD, panic attacks, mood disorders, relationship issues, research and technology. And I am thrilled that he came to join us today. Those are issues that I know all my students are facing just based on conversations I had in class literally yesterday. So I'm thrilled that you guys can join us on this talk, and I'm going to go ahead and back off and let Dr. Scofield take over. So again, thank you.
Thanks, Daniel. And it's a pleasure to be here to speak with you about the work we do at the Center for Collegiate Mental Health. Again, I'm Brett Scofield. I'm the Executive Director for Center for Collegiate Mental Health at Penn State University. It's otherwise known as CCMH. I'm going to talk for about 45, 50 minutes-ish. And then at the time, we'll have at the end, we'll have about 10, 15 minutes for you to answer questions or ask questions in the chat that hopefully I can get to. So here are the topics that I plan to talk about today. First of all, what CCMH is and what we do, some of the recent mental health trends that we have in collegiate mental health, the changes to counseling center service delivery models over the last 5 years, and especially since the onset of COVID, our annual report history, and then our special topic for this year, which was students' experiences of discrimination. A big thank you before I get started to all of our members at the Center for Collegiate Mental Health. We have over 800 institutional members. And then our collegiate mental health community, the CCMH staff, advisory board, and all of our electronic medical record partners. So the beginning of CCMH, I want to take you back to 2004, and approximately 20 years ago. And we knew the landscape of collegiate mental health was changing even then. Counseling centers were experiencing an increase in demand for services. Students were becoming much more comfortable asking for mental health help. And when the increasing demand happened, counseling centers were becoming overwhelmed. There was some high-profile suicides at the time. And then really, we didn't have a cohesive voice or any cohesive data about what was happening. And so what would just win the day would be opinions, and usually the person with the most loud opinion would win the day. And it was basically information or policies that were made on anecdotes and just personal experiences. And what Dr. Ben Locke did, who was a psychologist at the counseling center at Penn State at the time, was that why don't we collect standardized data as part of the routine practice when students receive counseling services nationally, and let's make that data standardized so student A in California can be compared to student B in Maryland. And that way we can have a cohesive and comprehensive understanding of what's happening in college mental health nationally. And that movement expanded over time to where it started as a few centers, and now it's over 800 institutional members as part of our network. We collect data as part of the routine practice when students receive counseling services. So the data I'm going to show you right now is the subset of students who are receiving mental health services nationally. It's not survey data. It's not general student body data. It's data of students at the counseling services. It's actually the people who are students in clinical care. Our impact last year, we had for 2022, 2023 was 775 plus centers. We had over 7,500 clinicians who used our tools, and over 660,000 students in treatment nationally received benefit from the tools and the feedback our data offer. So data dissemination, that's one of the key missions of what we do. So the data we collect as part of the routine practice when students are in care, we use that data to inform the tools and the feedback that we give to centers so they can provide that to students who are in treatment, and it benefits those students who are in care. So our network is a feedback loop. So we get de-identified data and we use that data to give back to centers so they can advocate for services and improve the care they provide to students nationally. Some of our common data dissemination efforts are our monthly blog that we offer that's on our website here, and then our annual reports. And our 2023 annual report is coming up here in January 2024. I'm going to give you a sneak preview of what's coming in our annual report. Pretty much everything I show you today is not available to the public yet, but I'm choosing to share it with you before it goes live as a way to understand what's happening in our latest round of data, which goes all the way up to summer of 2023. Our data sets are really large. We had over 185,000 students in treatment who contributed information to our data pool this year. This is self-report data from students when they enter in counseling services. And these are some of the clinical variables that we collect data on. And you can see the 13-year trends here on some of these areas of distress. And you can see here in the last year, depression has actually gone down a little bit. Generalized anxiety, social anxiety have risen a little bit. And what you notice from this is that across the 13-year trends is what stands out are some of the areas of distress that increased right after the onset of COVID, which is this line right here. So social anxiety, academic distress, eating concerns, and family distress are all areas of concerns or distress that experienced a bit of a bump during COVID. And you can see here, only academic distress is receding. Social anxiety is continuing to rise. Eating concerns is flattened, but it's certainly not going down. And family distress is continuing to go up. When you look at what's changed the most in the last 13 years, we hear a lot about anxiety, but it's specifically social anxiety that has increased the most in terms of students' symptoms when they come in for care nationally. It's increased slightly more than generalized anxiety and depression. When you look at rates from 13 years ago, about 26% of students came in nationally with elevated levels of social anxiety. In this past year, that's risen to about 37%. So there are changes in anxiety, and specifically social anxiety. When you look at the symptom of social anxiety that's changed the most, it's concerns that other people do not like me. So it's that social comparative process that we see that's probably fueled by social media, and also by when students were isolated during COVID, then abruptly had to come back to campus and encounter some of these in-person social situations that they were able to avoid for about 18 months. When you look at students' prior treatment trends, these are students who have had a history of mental health treatment. You can see here, we're at a high watermark in the last year in terms of students who are coming in with prior counseling and prior psychotropic medication use. Over 61% of students nationally are coming in with a prior counseling history, and about 37.5% are coming in with a history of psychotropic medication use. History of psychiatric hospitalization has remained pretty much flat over the past 11 years. Threat to self characteristics, these are characteristics of students who engage in self-harm, thinking about suicide, or the attempted suicide. And you can see here, most of these before COVID were going up, and then there was a decline in a lot of these during COVID with some rebound. And what happened is that we think during that remote year of services is that many of these students returned to their prior therapist that they saw at home or dropped out of treatment. But again, after we came back to campus a couple years ago, we've seen a rebound in students coming in for services with threat to self characteristics. Threat to others, these are characteristics about students either behaving in a way where they're causing injury to others or they're thinking about it. This has been relatively flat over the past 11 years. Trauma, history of trauma. This is something that should be on all of our radars as we work with students. Students are increasingly coming into counseling services reporting a general history of trauma. You can see the trend line here. And even unwanted sexual experiences or harassing behaviors, that's also trending up. But general experiences of trauma are increasing substantially. So 11 years ago, 31% of students came in reporting a history of trauma. This past year, it's 47%. That's a pretty substantial change in about 11 years. We delved specifically into what types of traumatic events are increasing the most, and there's two that stand out. It's childhood emotional abuse. You can see that here in this yellow line, and then history of sexual violence. Those are the two specific types of traumatic events that are accounting for the change in general trauma. All the other specific types of traumatic events were generally flat or unchanged in 11 years. So again, childhood emotional abuse and sexual violence. Alcohol and other drug use variables, treatment or binge drinking, etc. These are things or characteristics that have been generally flat or declining in counseling centers nationally. The exception is marijuana or cannabis use, which has gone up but flattened, but plateaued, I would say, in the past few years. This does not mean that students are not experiencing substance-related concerns on campuses. It just means that these students are less likely to go to the counseling center potentially for those concerns. A lot of these types of concerns or problems, especially in larger counseling centers, have been negotiated where they're treated at an adjunctive center like a health promotion and wellness center, or anybody that has offenses related to alcohol or substance uses on their campus. They go through a standardized program, but it's generally not done at the counseling center anymore. So that's what I think we're seeing in some of this trend data. I'm switching here to when you ask therapists why students are coming in to counseling nationally. This is our therapist data. So of why they say students are coming into counseling services. You can see anxiety, depression, and stress are the top three concerns. And that's generally been the case across years. Anxiety has gone up a little bit. Stress, depression went down a little bit. Stress remained flat. But the thing that's most notable about what therapists are telling us, it corroborates what students are telling us, is that this green line here is that students are increasingly coming in with history of trauma. This is a figure that shows you when therapists can check all the reasons why students come in. But we also ask therapists to tell us what's the primary reason why someone is coming in for counseling services. And you can see here, anxiety increased ever so slightly in the past year. Depression is actually declining as a top primary concern. But again, you see here the trauma is increasing as a primary concern of why students are coming in for services nationally. I want to speak a little bit to some of the counseling center service changes that have happened, especially since the onset of COVID. You can see here, this is a breakdown nationally in terms of students when they went through courses of treatment at counseling centers, what percentage used all in-person, what percentage used all teletherapy, and then in the yellow, it's who used hybrids, so some combination of in-person and teleservices. And I would like to point out that first year after the onset of COVID, about 3% of students were seen for all in person. So in the red here, you can see almost the entirety of service delivery that first year of COVID was all teletherapy. And you can see here it's rebounded a bit to now about 50% of students in this past year received all their services in person. So you see a rebound from those initial stages of COVID to students who are receiving exclusively in-person services. And the rest, 50%, is split evenly between people who get some kind of hybrid, in-person teleservices, and then only a quarter of students at this point are exclusively seen for teleservices nationally. Students, by and large, when you ask counseling centers, strongly prefer that in-person experience and in-person therapy. I would say the overwhelming majority do. I want to show you something from that a figure I put together that uses a combination of our data, which CCMH, with the Healthy Minds study, which uses more general student body data through surveys. And this is the landscape of collegiate mental health in 2017-18, so about 6 years ago. And this is the Healthy Minds data. So about 6-7 years ago, 27% of a student body reported that they've had mental health treatment of some kind in the past year. That could be seeing a medical doctor, physician, a therapist, the counseling center, et cetera. So it's about just over a quarter of the student body. And about 12.5% used the counseling center. So there was this 14.5% gap of students who are in a clinical population who are not using the counseling center services. I want to show how this has changed in this past year. So that gap has widened. So if you look at the students who are now report having clinical treatment for mental health services in the last year, it's about 36%. So that's gone up. And then counseling centers, it's gone down a little bit. Most of that could be related to many things of why students might be enrolling or utilizing counseling centers at a little bit of a lower rate. Part of that has to do with enrollments at colleges and universities have declined at some institutions. And also students just have more options for care. They can remain, they can use a telehealth service. They can use a company. They can also remain in telehealth services with a therapist that they see over the summer. They don't have to transition necessarily to the counseling center anymore. And that gap you can see now is about 25%. That's good in one respect because counseling centers, if you look at, again, 6-7 years ago, counseling center services were on an unsustainable course of having demand override supply of services. But now you can see that counseling center services that we're able to distribute that care across a bunch of different options for students. But this gap does have implications for faculty, staff, and other people who work at institutions because care has now been fragmented. So you're much more likely to work with a student now who is just in care with a provider and might need accommodations or might need some communication with their therapist because of some academic consideration they might need. And you're more likely now to be talking to a provider who might not have experience working in the higher ed system or working with this particular kind of situation in an academic environment. So it leads to sometimes inconsistencies in documentation and consultations with faculty and staff. So there are implications. I want to show you here too about how that share of students who are using counseling services, how that's changed demographically in the last 11 years. This involved figure here looks at the racial demographics of students who are receiving care nationally. And you can see here about 11 years ago, there was about 29% of students nationally represented racial diversity at counseling services. That is now 40%. So counseling centers are increasingly treating a greater proportion of students who represent racial diversity nationally. And the largest group that has grown are actually students who identify as Hispanic, Latino, Latina, Latinx. That's gone from about 8 to 12%. This is also something that's been a considerable change in who counseling centers are treating nationally are students who identify as LGBTQ+. So that was 13% of students 11 years ago. It is now 35% of students who are treated nationally identify as lesbian, gay, bisexual, queer, questioning, or some other identity, diverse sexual identity. And then finally here, this is gender diversity. About 11 years ago, less than 1% of students identified as gender diverse. That is now about 6 to 7%. So counseling centers are increasingly treating students who represent diversity in terms of the proportion of services, proportion of the clinical population that are using services. I want to take you through a little bit of our history of what we've learned from our special topics of our annual reports in the last 7 years to better understand where we are right now. So the mental health narrative over the last 6-7 years has been very crisis focused. Students coming in with increasing mental health needs, mental health supports, and that is true. And we actually looked at that about 6-7 years ago and looked at how much counseling services were experiencing an increase in demand. And we found 7 years ago that way surpassed enrollment rates. So the common myth is that at the time in 2015, of course, counseling services were experiencing an increase in demand. College enrollments were going up at the time. But we found that demand for services was rising at over 5 times the rate of enrollment. And when we have rising demand for services without concurrent focus on the supply of treatment available, counseling centers have to do something to accommodate that demand. And what we found is that clinical models shifted from routine care focus to rapid access focus, where you can get students in quickly to assess them and triage what their needs are. The rising demand that we have seen for counseling services is occurring for a variety of reasons. One is destigmatization of services. Students are just much more comfortable asking for care than they ever were before. We also know that suicide prevention programming and students of concern programming that have been amplified, especially since the Virginia Tech shooting in 2007, we've increased our efforts at identifying and referring students in need of care, and that has been successful. And then the third reason we think that there's been rising demand for services is the K-12 system. Many, especially resourced educational districts or K-12 districts, have an abundance of counselors and make that available for students in the K-12 system. So they are much more likely to come in with expectations and feel very comfortable to ask for mental health support when they need it. But again, you have the rising demand for services. Without the concurrent focus on supply, counseling centers have to accommodate and shift their clinical models. And one of the outcomes of this is that there's rising caseloads of clinicians and students experience poorer outcomes. When caseloads of clinicians rise, students experience less treatment that's more diffuse, and they experience poorer outcomes. In this last year, in 2022, we looked at how counseling centers contribute to student success, and student success measured by whether they persist in school during treatment. And we looked at an abundance of risk factors at the outset of treatment: chronic, acute, therapist-assessed, situational, and demographic risk factors that predict whether someone might leave school during counseling. And then we secondarily looked at whether there were factors that happened during treatment that serve as protective factors for students persisting in school. And we found a ton of risk and protective factors, but most importantly, when you put these all in a model, the risk factors that predict whether someone will leave school, so that means withdraw from the institution, are whether they've had a psychiatric hospitalization, whether they're academically distressed right now, and whether they identify as a first-year freshman. The average withdrawal rate nationally for any student. So if you know nothing else about a student, you can probably predict that about 2.8%, which is this bold line, will withdraw from school at any given time. But this group, when they have these risk factors, at a withdrawal at about 3 times that rate. Now, we also looked at protective factors, what makes someone less likely to withdraw from school. And certainly change, when they experience a symptom change in anxiety and depression, predict that. But in particular, if their academic distress changed, if their academic distress improved, and they were concurrently involved in some kind of extracurricular activity, they were about 50% less likely to withdraw from school. Before I get to our current topic that we looked at this year, I want to share with you this is not a CCMH study. This is a slide that we put together that uses a combination of different studies to show suicide risk for college students compared to the general population. When there's a suicide at a college or university, one is too many. This is something that impacts the campus and the community in profound ways. And we also know when these situations happen, sometimes it's amplified in the media and there's a lot of attention drawn to it. And sometimes the attention is negative and there's blaming that happens towards colleges and universities and the counseling centers themselves. And when you look in the data, it actually shows you that college students are at a significantly reduced risk of following through and being successful in committing suicide. The orange bars here represent the rate per 100,000 of college students who commit suicide, and the blue bars represent the rate of suicide for their same age peers in the general population. And across the board, with the exception of this study from 1920 to 1960, college students represent half the risk of their same age general population in terms of suicide risk. I think this can be pointed to as that being in college is a protective factor against suicide. And we can hypothesize why that might be the case. Students have enhanced support services. They have people that they can reach out to that provide assistance. There's also stricter policies about firearm access on many colleges and universities. All these, I think, combine together to reduce risk for this group. Now I want to transition to our special topic for this year. And we've particularly focused on students' experiences of discrimination. If you go back to May 25th, this would be about 10 weeks, almost to the day, after the onset of COVID and after COVID-19 was declared a pandemic by the World Health Organization. May 25th, that day has a very significant bookmark in our history because it was a day that George Floyd was murdered. And the reckoning that occurred after that. If we can remember that summer and that June about the protests and the focuses on the issues of racial equity and discrimination, about how much we were tuning to that in the moment. And we had at CCMH the same interest about, can we explore this issue when students come in for therapy? At the time, we did have a measure of discrimination, but it was only if you ask a therapist if a student's coming in with a concern about discrimination. And that was endorsed at a very low level. The question we had was, what if you ask students about whether they've experienced discrimination based on one of 6 identities in the last 6 months? And we spent about a year piloting and formulating this question about whether students have experienced discrimination in the past 6 months based on any of these 6 identities. And it was rolled out nationally on July 1st, 2021 to counseling centers. And we now have data on this from 2 years. And about 20% of students who come in for services report discrimination of some type based on one of those 6 identities. It's about 1 in 5 students are sharing that they've experienced discrimination in the past 6 months based on one of those 6 identities. You can see that 8.4% of students are reporting discrimination in 2 or more areas of their identity. We had specific questions about, does discrimination is not a mental health concern. Discrimination is a societal problem that needs to be addressed. And at the same time, we had questions about, does it correlate with mental health distress? And if it does correlate with it, how important is that variable of knowing about someone's history of discrimination compared to some of these other historical variables that we collect, that we quite frankly have been collecting, been trained to collect for the last 100 years in psychological services. And then our third question was whether students who experience discrimination compared to those who do not, do they experience comparable levels of improvement in care at counseling centers nationally? Question 1, is discrimination related to mental health distress? Absolutely. This was a profound effect. So we looked at whether discrimination was related to social isolation, general distress, and suicidal ideation. And you can see here the gray bar are students who experienced no discrimination, and the green bars were respectively students who experienced one area or multiple areas of discrimination. And you can see here, if a student experienced multiple 2+ areas of discrimination, they were even more likely to have suicidal thoughts, distress, overall distress, and be isolated socially. We also wanted to look at how important is it knowing about a student's experience of discrimination compared to other historical clinical variables that we routinely gather when we meet with students. So at the bottom here are typical clinical mental health history variables that you gather from a client when they come into your office for the first time. Have they ever attempted suicide? Have they ever been in treatment? Have they ever experienced a traumatic event? And you can see here across the board, these are typical variables that we collect. Right here, this bold line, 1.85, is the average level of distress that a student, that students come in for nationally. So one way to think about that is if I know nothing else about a student, this is the level of distress that I would predict that they would have. We would, based on our history, we would assume that people that have these substantial mental health histories would come in with a higher level of distress, and we are correct. So our history, our training is justified, that we are collecting these variables for a reason, because they predict how distressed someone's going to be, and it impacts our disposition or our treatment plan with these students. Our follow-up question, though, is how does discrimination fit in this picture? And it's remarkable. This is something that we haven't collected historically, but when you look at whether students experience one or multiple areas of discrimination, it matches up. It's comparable to predicting the level of distress as these historical clinical variables that we have always collected. And you can see here, when you look at how it predicts overall distress, someone's had multiple areas of discrimination, it's almost as predictive of how distressed someone is as whether they've had a prior suicide attempt. When you look at now how discrimination compares to these historical clinical variables and whether someone, how suicidal, or the level of suicidal thoughts, you can see also it matches up pretty fairly well with these historical clinical variables, with a prior suicide attempt understandably being the most prominent predictor. And then when you look at how discrimination matches up to historical clinical variables and how isolated students are, again, same picture. It is equivalent to many of these mental health history variables, and actually, if someone's had 2 or more areas of discrimination, it's almost as comparable as a prior suicide attempt in predicting how isolated students are. Our third part of this question is students, when they go through counseling services and experience treatment, how do they improve in overall distress, social isolation, and suicidal ideation compared to students who have no discrimination? So the green bar is the change from the beginning of treatment to the end, or the first and last administration of our tool, how they change compared to the gray bar, who are students who report no discrimination. And you can see here, these numbers are the raw change. And across the board, students who experience discrimination experience comparable improvement in overall distress, social isolation, and suicidal ideation. And actually, students with discrimination even experience a little more change than people without discrimination on suicidal ideation when they go through services at counseling centers nationally. So that's one part of the picture, is that counseling centers are effective in supporting students with these discriminatory experiences. But part of the picture here, as I'm going to point out, is that there's an improvement gap. So because students who come in for services with histories of discrimination start off treatment with higher levels of distress, they end treatment with a gap, with higher levels of distress than students without discrimination. And we call this improvement gap. And what this really speaks to is that that while counseling centers are effective in treating these students, there's an array of adjunctive support services that are needed at colleges and universities to help further close this treatment gap. So this really speaks to that diversity, equity, inclusion, and belonging initiatives on campuses are critically important. Again, discrimination is not a mental health concern, it's a societal problem, and DEIB and mental health are linked. So if our colleges and universities are speaking about wellness and about mental health, they can't ignore DEIB initiatives. These are needed in order to close these treatment gaps, these outcome gaps and improvement gaps between those who experience marginalization and those that do not. I'd like to, I'm starting to wind down here to the end of the presentation, but one of the things I just want to say about counseling centers is that counseling centers, and really all of our collective wellness services, are critical to serving this, supporting the mission of many institutions. Many institutions right now, in addition to some of them are having financial struggles, we're having enrollment struggles, and many of them are just focusing on wellness and mental health, student success, and diversity, equity, inclusion, and belonging initiatives. These are all critical pillars of many institutions right now, and counseling centers support all, and our wellness services support all of these. When students come to counseling services, they experience improvement. As a matter of fact, our research from 2017 shows that improvement is equivalent to the effect sizes that you see in randomized clinical trials, which are the gold standard in psychotherapy research. We contribute to student retention. We contribute to student persistence. When students change during treatment, they're more likely to stay in school. And our recent analysis that we're releasing this year about students' experiences of discrimination, how the risks that create for mental health outcomes and the support the counseling centers provide is critical. And we know there's still that improvement gap that's really speak to the need for colleges and universities to support DEIB initiatives, not take them away. So key just summary of what I talked about is that if you look at the mental health trends, social anxiety and trauma continue to have the largest increases in the past 11 years. After the onset of COVID, after that first year, students are now increasingly using in-person services, about 50% of them exclusively use in-person services. It'll be interesting to see how that trend might change next year, or whether it ceilings out at that 50%. Utilization on average is slightly down at counseling centers since the onset of COVID. That's due to multiple reasons: decreasing enrollments, more service options for students. But importantly, counseling centers are increasingly treating a greater percentage of students who represent racial, sexual identity, and gender diversity. And our special topic this year really shows about how discrimination is correlated substantially with mental health distress, isolation, and suicidality. Counseling centers are very effective in supporting students with these concerns, and more macro level supports and DE/B initiatives are needed to close those improvement gaps. Counseling centers, again, are key to serving the missions of institutions. We contribute to wellness, student success, and DEIB. One thing I just want to leave us with is and this is not really CCMH, but more a hypothetical of what institutions are doing to try to solve wellness and mental health problems on their campuses. Is that we know that we need a continuum of care and a wide array of options to support students that go beyond just treatment or tertiary care. So in prevention science, you have primary prevention, which is, and I know everybody here knows this, that primary prevention is the preventing a problem before it starts or before it occurs. And this is what generally colleges and universities are doing to try to put things in place at the primary prevention level, which is institutional wellness initiatives, peer support programs. Then you have secondary prevention, which are those students who are in the early phase of a problem, or early intervention is needed. We're putting programs in place to address that. Let's Talk programs, which are abbreviated consultation or problem-solving sessions that many counseling centers or other support services do with students, coaching, self-help platforms. And then tertiary care is what we traditionally think of as treatment, which is done at the counseling center, and that's the individual and group psychotherapy, crisis services, teleservices. You hear these terms in higher ed right now: downstream, upstream. So downstream is the philosophy of when you have student concerns, you push everything towards tertiary care. We do know that if you do that without concurrent levels of support for the counseling center, that you can, again, create increasing demand for the counseling services, rising caseloads, and diffuse care for students, and they don't improve as well. Upstream is the focus on how do we go to problems before they need tertiary care interventions or tertiary level interventions. And that's focusing on some of these secondary and primary levels for support programs. This is what colleges and universities, we're in the early stages of being able to try to figure this out. And we see a lot of efforts in this direction. I will say this, is that we are not operating with the best data on this yet. The science on this is early. I think one of the projects we're working on with CCMH within the Penn State system, and potentially in collaboration with other colleges and universities, is trying to understand from day one, when students start or matriculate to a campus, what are their mental health needs? What are their symptoms? What are their historical needs? And we want to track those over time to answer like who needs what services, and importantly, when they might need it. And we would be doing that to understand how people progress through their educational career, to determine what interventions might be needed for who and when they might need it. And I think the science on this is early, but I think in the next 5 years, we might have better answers within higher ed to be able to inform these continuum of care options. I am exactly at 45 minutes. So I wanted to thank you for your time and open this up to chat questions. And I think Daniel is going to come on to help facilitate that. I do want to say there is a QR code right here that is a sign up for our newsletter. Our newsletter, I promise, is we don't bombard people with communications. It puts out news when there's news, when we have new findings that might be relevant to your to higher ed. When we're offering national programs, you can sign up right here and you will know about it. We average about one notification a month. So we certainly do not flood your email with any kind of newsletter announcements. And just I want to put a plug, this is free. We offer these continuing education programs for free. And our next one is on April 24th, 2024 from 12 to 2 p.m. Eastern. And it's on socio-political stress and college student mental health. We have a wonderful group of speakers here that are going to tell us what we need to know about this topic, especially as we head into a very, what's anticipated to be a challenging year coming up here with election and other socio-political events happening. I'm going to stop talking, and I think Daniel's going to come on here, and I'm happy to answer any questions in the next 13 minutes.
Hey, Dr. Scofield, thank you so much for that. We have a couple different things coming up, and I know I think 2 of them emailed to me. So we'll start with what's present in the chat first, and then I'll ask the email ones as we have time.
Okay.
So I have a comment from Daniel Boyd, which I'm going to put up on the screen. Discussing that variables relate to access to housing, medical care, food, transportation have been added to your data set. When will that data be available?
Thank you so much for your detailed question. That is absolutely correct. That item related to, it's an insecurity item related to food, housing, medical care, and also transportation and educational supplies, educational materials. It's a comprehensive item related to insecurities, and we rolled that out on July 1st of 2023, so just a few months ago. We will probably be able to get an early look on that data in February, March, but probably will not be able to have a full inquiry of it until about a year from now. So it takes, we do data cuts about twice a year. So we might get an early look again in the spring, but probably more likely it will be early fall of 2024. We're very excited to see the initial look at that data. Thank you for that question.
All right, we got another question from Melissa Bopp.
Hey, Melissa.
So throughout for a great presentation. Also, any tips or ideas for how faculty can adapt classroom policies to help with the increased rates of stress and anxiety?
Yeah, it's a great question. I know that there's different institutions have different policies about what you should put on your syllabus or how you can address some of these resources up front. I'm a believer, if you are creating syllabi for students, that you put an array of services that can help them, because students might come in and have anxiety or stress, but they don't necessarily need a clinician to be able to support them in that moment. They might need academic tutoring, educational support services. I mean, if you look at our data, academic distress is one of the key variables, and academic that predicts whether a student remains in school or not. And academic distress is not necessarily a clinical syndrome. It sometimes can be related to anxiety and depression, but it also is something that a non-clinician can support. So I think it's really important to be nuanced in when you work with students, to understand what their needs are, because they might be stressed, but the thing they might need is not necessarily a clinician, but some kind of academic support, or if you do this in your classroom, an academic consideration in order to get them through in that moment. Great question.
I'm actually taking notes. I started realizing, wait, I'm also doing this. Hang on. So with that being said, let me go ahead and pop the question in terms from an admin standpoint. So as a chair and or dean, what would the recommendation be to really support your students, especially since they face the issues of enrollment retention that they get brought up, and knowing this definitely faces those that directly affects their job? What would be the best bet for them to empower their programs and their students inside those programs?
Yeah, it's a great question. So I will say this, we get a lot of questions from different academic programs about their students. And there's a lot of questions about, are my students experiencing more distress than this other department? And and I think sometimes it's helpful for us to look at students within a given department, but we do know that just students are struggling everywhere with a variety of different concerns across departments. So I think it's important for any dean or any administrator to think about that, regardless if you are feeling this locally. I think in terms of, it's important to know again what your resources are. So what do I have as support services for students? What are the referrals I have? And I think you have to know the mental health support services, but also what are these outside these co-curricular investments that I can have with student affairs or other support services that might address this student's concern. Educational support services to help students remain in school, I think are critical. One of the things I didn't talk about that I'm sure you have seen is that students, especially since the onset of COVID, are operating differently than before they did than they did before COVID. Students appear younger than their chronological age. We get this comment a lot. Not all students, but some students appear more developmentally younger than their chronological age. We actually just offered a national presentation on some of this, on the why that's happening. But they missed for about 2 years a lot of developmental milestones that are impacting how they're behaving right now or how they're interacting with you. And I think that needs to be considered when you're working with students, is about, I am going to be sometimes working with a student who might be this particular age, but this particular development that's off. And I think that has to be part of what the discussion about how we help students close those gaps. And I think it's going to be around for a while. A traditional age college student right now, starting, so that's maybe 18, they were, doing the math here, they were 15 when COVID started. They didn't have they were maybe a first year student in high school.
Well, that kind of leads on to the next question a little bit, that sitting in enough meetings across both the national spectrum and sometimes inside institutions and in systems, there's always that whole, well, I was a student once, I figured it out. That's kind of the whole purpose, is that you're supposed to get in here, figure it all out. And you kind of treating college almost like a crucible, right? Like to become the adult that you're going to be. How do you answer that response? Because sometimes that is dealing with more senior faculty or faculty above who've been doing this for 34 years. And they're just like, nope, it's the same. You just got to toughen it up.
Yes. Yeah. I mean, I definitely understand that perspective. Our collective experience as one generation might be very different than another. And I hear that a lot. And I will say that I don't think we've collectively have quite figured this out, but intergenerational interactions and intergenerational expectations can create discordance. It can happen not just with faculty and students, it can happen just within departments, intergenerational employees, about how our approach to work. It can be very different culturally between someone in my generation and someone else's generation. It's really important to think about that, I think, just beyond interactions with students. I do think if that students are coming in to college with different support needs than they might have 20, 30 years ago, or when someone maybe at my age or older was a student. And we have to think about applying a different flexible template there. It doesn't mean they're not going to learn what we learned, or they might get out of stuff, but they might have a different pathway to success than we did. And I think we just have to be flexible about that. I think it's a reality. Not all students are going to have those needs, but it is a consideration. And again, I think that needs to be thought of in the workplace. So.
Absolutely. I know we're last conversation I had on that specific topic of workplaces. In higher ed, we're at a point where we can have 4 different generations inside the professoriate and staff area, and a very different view of the world from every single generation.
Yeah. We had a similar conversation, Daniel. Absolutely, at 4 different generations working in the workplace together, and we can all be rowing the boat in the same direction, but sometimes have different approaches to work, and that really needs to be transparent and thought about. Yeah.
So the last question I'm going to leave you with then is, how can deans, chairs, faculty be better advocates?
I absolutely 100% believe that the programs that are going to be in place in the next handful of years to the next decade are going to be co-curricular. They're going to be a combination of student affairs and academic. It's going to be a community-wide effort in order to create a wellness-oriented university, and one that is addressing mental health. I think it's important to understand each college and university is different, but I think it's important to understand what is going on within your student body, what services are available. Are your counseling services overrun? Are they overrun with high caseloads? And are all of our efforts like pushing things downstream? And does that make sense right now? And if that is what we're doing, does the counseling center need more support services? So we have I didn't specifically talk about today. We have an index called the Clinical Load Index, which shows what caseload counts are at the counseling centers. And it's important to know what those are at counseling centers, because it predicts what the student experience is going to be like at that counseling center. And it can create more realistic expectations of what the counseling center can do with students who seek services there. But again, I think that it's not just advocating for counseling services, but it's what do we want this comprehensive program, if we want to do that, look like on campus, and how we want to support students who have clinical needs, but there's also non-mental health needs in order to succeed. And I think student success has to be a central part of that. Yeah, I think again, in the next handful to 10 years, we're going to have we need better science on this too. And that's my passion, is to try to understand this better for, again, like who needs what services and when they might need it, in order to try to tackle this dilemma.
Absolutely. The idea of a holistic approach definitely, I think, does a better job fitting today's needs with students and our requirements placed on them. So with that, I'm Dr. Daniel Burt from Texas A&M University Kingsville, on behalf of American Kinesiology Association, with Dr. Scofield from Penn State, and a Center from Collegiate Mental Health. Dr. Scofield, I highly appreciate everything you've done. I actually had one question pop in the chat just now. Do you want to give it a quick shot?
I have a couple minutes here. I'm happy to answer it. By the way, you're very welcome.
I'll cut it off after that one. But I appreciate you guys. Nancy Williams, since I want to make sure I catch them all if I can. Brett, you expect whether an academic unit like kinesiology play a role in screening for mental health issues. This is what we want to try at Penn State, but perhaps you could elaborate on whether this might be a viable model across the country, where curricular offerings could be linked to mental health services.
Hi, Nancy. I think we talked yesterday. Absolutely. I think we have tools in at CCMH. There's other tools that are available as well. But to be able to screen students when they first encounter you, to understand what their needs are, I think is very important because, again, it can identify who is at risk potentially not succeeding, and you're able to identify what support services they might need in order to be successful at your college and university. And successful is being able to complete their classes. I mean, that's certainly why they're there, but it's also able to be well and healthy. And I know we have common goals in that area. So I think early screening that's standardized and scaled, so where you can get your whole group of students that you are intending to intervene with, I think is important. We have screening tools that are available in that way. And I think we're in the early stages of being able to do this with academic units or divisions within colleges and universities, but doing more mass screenings to be able to identify students at risk, and how to get them the support services they need. And again, that could be mental health, but it also could be non-mental health support services. I think, Nancy, what you talked about can be a template for that nationally. Thank you.
All right, and Chris Grappendor just said thank you, appreciate it. Guys, thank you so much for the information. Dr. Scofield, it's definitely been extremely helpful. Thank you guys for tuning in. That being said, I will say this video will not be open to the public. After this, we usually do have them open to the public, but due to data sharing that's taking place at the moment, we're gonna go ahead and put that behind the login for AKA. So if any of your members, because you guys belong via departments, need access or you'd like to share it, absolutely, please just go ahead and log into AKA, and we'll have that posted probably in about 48 hours, and you can watch it there if anyone you want to share with inside your department or expand it out. So again, thank you, Dr. Scofield. It's been a huge pleasure, and again, a topic we've wanted to talk about for well over a year. So thank you for sharing your expertise.
Thank you, Daniel, and also thank you to the American Kinesiology Association, Melissa Bopp, who asked me to do this presentation. Happy to do so, and I appreciate all the great questions. This was an honor to be here. Thank you.
All right, thank you, everyone. We're gonna go ahead and cut it now. Have a great set of holidays and wrapping up the hopefully less stressful end of the semester. Take care.